So it's my pleasure to introduce Donna, who's a consultant research therapist at Imperial College Hospital.
Well, my slides, okay, lovely. So I think after this intense morning and the start to the afternoon, you can probably rest your brains a little bit listening to my talk, because I suspect it'll be a lot less challenging. So the image here, it's from an app that will take your publications from Google Scholar and create a word cloud. And as you can see, I've spent a lot of my time studying hands, and I really thought that at this point in time, I'd have a lot more answers than I do. These should really be acknowledgements rather than conflicts of interest pertaining to my funding and illustrations in my talk. So today I'm going to give a sort of whirlwind tour of looking at individual pathophysiology to address rehab needs, extrapolating evidence from other conditions, looking at evidence for scar care, and then how we are doing work to improve standardization in scar evaluation. Back in 2014, Sweet and Blackmore published a study looking at, it was an update of surgical and therapy rehab in patients with Dupuytren's, and they concluded that in the previous decade, there'd been very little advance in the hand therapy management of patients with Dupuytren's. And I'd have to say, in the subsequent decade, there's been very little additional primary research done. So it's really exciting this afternoon to see that my fellow therapy colleagues internationally are engaging in primary research to improve care and outcomes for patients with Dupuytren's. So as long as Dupuytren's has been described in the literature, splinting for Dupuytren's has been described in the literature. Back in 2011, Tina Jerish-Harold did a blinded, excuse me, not blinded, but a randomized controlled trial, a multi-center study in the UK, and they looked at hand therapy post-Dupuytren's surgery with the addition of night splinting or without the addition of night splinting. God bless you. Patients were randomized to one group or the other. At baseline, measurements were taken to assess their total active extension lag, and then they brought back only the patients from the non-splint group at 1 week. And it's unfortunate they didn't bring both groups of patients back, because potentially they might have seen the same in both groups, but what they saw in those patients in the no-splint group, they used 15 degrees of loss of motion from baseline at the PIP or 20 at the MCP to convert patients to the splint group. And roughly 20% of patients, 17% from that no-splint group, required splinting. So the sort of takeaway message here is that while our surgeons do their magical work and restore extension to the digit, patients will quickly go through this process, or a proportion of patients will, where there's almost this regression to the mean. The hand resorts to that adaptive shortened position that's caused by the Dupuytren's contracture and the impact of that on the adjacent tissues. So we've had evidence for ages, all the way back to 1966 from Peacock, and this sort of seminal work has driven a lot of what we do in hand therapy, looking at low load prolonged stress splinting, looking at total end range time to help us form protocols for splinting. But perhaps as hand therapists, we need to apply this evidence around joint fibrosis better in our approach to rehabbing patients. So for example, with our patients that present to us with long-standing MCP flexion contracture, although yes, we want to measure and see, has the patient regained extension of the digit post-surgery, we should expect that with long-standing MCP flexion contracture, there'll be intrinsic tightness. And we have clinical tests that we can do to assess for that. So I would say if a patient has no intrinsic tightness, they probably don't need us. That's the proportion of patients that probably don't need hand therapy intervention. But if they are intrinsically tight and we don't address it through our splinting and exercise regimes, we'd be naive not to expect that flexion contraction to recur over time. In terms of boutonniere deformity and the PIP joint, I think the PIP joint is especially grumpy because it's been crying out to us for a long time and we're not necessarily listening. So Kuhlman back in the 80s described boutonniere deformity in Dupuytren's disease. And then subsequently, in 1994, Paul Smith described central slip attenuation as a reason for that persistent PIP flexion contracture post-surgery. Smith described the tenodesis test, where after releasing the volar aspect of the PIP, they would passively flex the wrist in the MCP joint, and if the PIP, the affected PIP, didn't extend, you would anticipate that the central slip was attenuated and needed to be protected with splinting. Well, we've had lots of work in therapy specific to looking at central slip injury, and Roz Evans from Florida, she did some seminal work back in the 90s looking at using constrained motion at the PIP joint and gradual restoration of mobility. And this work that she did in repaired central slips was then extended to patients with closed central slip injury. But interesting that this work came about in the 90s, and it wasn't until 2013 there was a study actually exploring this in Dupuytren's patients. So in 2013, Terry Skirvin and Lee Osterman, in a case series of patients where the patients had at least a 40-degree flexion contracture of the PIP joint, they treated them with collagenase, and then they used a series of temporary immobilization of the PIP and then progressive mobilization, including mobilization of the DIP joint to mobilize those tight lateral bands and oblique lateral ligament. In that cohort of patients they examined, they only had a 4-week follow-up. And so it would be a really great opportunity for someone looking for a project to do such a study in a longer-term follow-up to see if their excellent outcomes that they had at 4 weeks are maintained better over time. We can also look at evidence that we have around how we might use relative motion splinting. So back in 2000, Wendell Merritt described the use of relative motion splinting in patients after extensor tendon repair. In relative motion splinting, the idea is that the affected, in this hand, the ring finger, the affected MCP joint is held in slight flexion, approximately 20 degrees relative to the adjacent digits. And this allows the exploitation of the extrinsic and intrinsic extensors to support that PIP into active extension. It'd be a useful opportunity for us, and I know anecdotally therapists are using this approach in patients with Dupuytren's disease, but in terms of research, I haven't yet seen in the literature a report of this being used effectively with patients. Anecdotally, we can see that patients get on well with yoke splinting because, as you can see in the images, there's very little restriction to hand flexion, and it sort of maximizes function. So sort of in summary around exercise and splinting after Dupuytren's surgery, while we hand therapists love to measure things, we love to get out our goniometer, and we're grateful for the free ones today. We love to measure the flexion and the extension lag, but potentially we should be more thinking about algorithms or decision-making trees about the affected soft tissues that are then ultimately going to impact that return to function. So testing the intrinsics, looking at the central slip, looking at the lateral bounds, is the flexor tendon shortened, and specifically personalizing that patient's care based on their particular soft tissue pathologies. So if we move on now to scar management of patients post-surgery, I'd say as hand therapists, we have a lot of work to do. Elaine Fess was one of the grandmothers of modern hand therapy, and in the 1990s, she said that hand therapists are scar therapists. But I think if we want to wear that tiara, we've got to do a little bit of work to earn that. So in terms of the types of things we do with patients post-surgery, there's a lack of standardization because there's a lack of evidence. So we know that moisturizing is probably good, and that it maintains skin hydration and decreases fibroblast activity, but there's no consensus in terms of what equals optimum hydration. And this impacts then how we speak to our patients about this. A recent survey in Australian therapists, burn therapists, inquired about instruction in hydration, and I think they identified something like 70 different products they advocated to their patients. In terms of silicone, it's probably our best evidence for both preventing and addressing hypertrophic scarring in patients in terms of its evidence base, but there's a lack of evidence regarding product selection or even treatment regimes, and we can certainly see in the UK that there's not equity in terms of how silicone is provided for patients. And then I think my particular bugbear is around scar massage. So although practically every hospital I've ever known has a patient handout sheet on how to perform scar massage, there's very little evidence for it. I know there's some talks later this afternoon, so I'm hoping they change my opinion. I mean, it's theorized that it's disrupting this fibrotic tissue, but in terms of the evidence available for the technique, the dose, the frequency, that's lacking, and any of the evidence for it, it's of low quality and inconclusive. And more recently, the mechanotransduction literature is suggesting that even more aggressive scar massage is probably likely driving inflammation and potentially driving scar tissue formation. So I think we need to think hard and long about what we're doing there. In terms of scar evaluation, well, we can't have good scar care without scar evaluation, but currently scar evaluation isn't standardized. We don't have gold standards, and we're really, in essence, probably asking two questions. From the clinical side, we want to know, is the scar normal or pathologic, and what treatments are feasible? But from the patient-reported side, those are the important aspects. Only the patient can tell us about their symptoms, their functional interference, or their psychological impact. So part of my work as a postdoctoral fellow has been to improve scar standardization. I'm in the process, and I'm collaborating with Professor Furness in this work, so it's been brilliant having a hand therapy, hand surgery approach to this. So if you're not familiar with core outcome measurement sets, core outcome measurement sets are agreed outcomes to be measured in clinical practice and research. The idea is that if you're measuring apples and I'm measuring oranges, we can't synthesize our results. The core outcome in measurement effectiveness group, or COMET, have sort of established processes for how this is done, which generally involves literature review, clinician and patient input, and then stakeholder Delphi studies. So where we've gotten to in our project, we did a literature review, and by state of the art, this means what's actually happening in practice isn't a brag that we were so cutting edge in our literature review. So we included 59 papers, 5% of them were in Dupuytren's cohorts. We could see that there's low uptake of standardized outcome measures, even poorer uptake of patient-completed outcome measures. Interestingly, 51% of studies looked at scar appearance or physical characteristics, but very rarely were they patient-reported. I mean, who better than the patient can tell you what their scar looks like, right? So then we also did a clinician survey. So with the clinician survey, we asked participants to rate on a scale from definitely not to definitely yes whether items should be included in scar evaluation. We used social media to recruit participants, and we engaged 162 SCAR experts from all world health geographical regions, so that was really impressive. 68% said they didn't use patient-reported measures in practice, and 69% didn't use clinician-reported outcome measures, but those that did predominantly used the Vancouver. So if we look at our survey and our review results in juxtaposition, we can see, so in the survey column, this percentage is the participants that said that something probably or definitely should be evaluated. So there's a high agreement on range of motion, that range of motion should be included. And then we can compare that with only 25% of the papers included in the literature, including that as an outcome. More importantly to me is if you look at the column on the right, these are the patient-centered concepts around acceptability and mental health impact. And in the review, we did very poorly as clinicians and clinical researchers. Only 10% looked at satisfaction, and rarely in the review did papers look at those sort of items around anxiety, depression, stigmatization, et cetera. So these items from the survey and the review will then be amalgamated to develop the first round of our pending Delphi study. Another aspect of SCAR evaluation that I'm interested in is looking at the clinical objective measures that we can use, so applying quantitative sensory testing to SCAR to look at heterogeneity in patient SCAR experience and trying to understand why do some scars hurt. In addition to using quantitative sensory testing, and this is a nice picture of a durometer, so I've used the durometer to look at tissue thickness in scar, and also using measurements to look at localized inflammation. I'm hoping that with exploring differences in scar this way, it'll help us to understand on an individual basis what drives scar symptoms and hopefully improve scar care. Some of my conversation with people the last couple of days, though, has made me think that many of these measures might be useful as well pre-surgery and looking to describe that phenotype in patients in looking at the involvement of the neurovascular bundle or in looking at tissue density. So we've learned a lot from patients thus far. In my research, what we can see is, yes, patients do participate in scar research, that they tolerate physical scar measures well. We had no dropouts or adverse events, and that patients, when they weren't actively receiving scar care, 70% of them were spending their own money to buy scar products and undertake scar care. I've been conducting focus groups in patients to identify what the priorities are in scar care and scar research, and patients consistently say they want more information about scarring pre-surgery, that they have difficulty identifying evidence-based advice because the internet is a minefield, that there's barriers to obtaining topical products, and they really want to know what treatment is best. So thank you for your attention. In conclusion, a plea, if anyone's interested in our upcoming Delphi study, which should occur later this year, or clinicians, patients, anyone who's interested, please feel free to get in touch. Thank you.
Thanks, Donna. Questions for Donna? Go ahead.
Any thoughts or input? There are two ways to measure elastic characteristics that you mentioned. One is ultrasound elastography, and the other is there's a device called a thermometer that's used in cosmetic surgery to measure basic. Are you aware of any experience with either of those applicants that use those technologies?
Is that specific to scar or specific to tissue in general?
Tissue, so elastography is used to measure liver fibrosis by measuring how stiff the liver parenchyma is. And the other is just used for plastic surgery. I just thought those might be, have potential use in scar assessment.
Yeah, I was weighing up the difference between a cutometer and a durometer and what information they provide for you. Yes, exactly. And because I have to beg the NIHR to pay for my research, I have to stay within a particular budget, which is sort of what led me to a durometer, because it's easily used in clinic, the results are repeatable, and it's quickly measured. Yeah. But we do lack tools. There's an engineer that I'm working with at Imperial College, and he's developed a tool that he's used to sort of calculate skin pliability, but it doesn't have a certification to use. So it's something he's made, and they've recently published a study looking at skin properties in patients with amputation and used this particular tool, but I'm not sure that I can extend that to hand based on the nature of the tool. Sorry, I don't have better information. Yes, sir.
How do your patient questionnaire results compare with the standardized questionnaires which are used by occupational therapists for things like, can you pick up a kettle or make a cup of tea? How do your measurements of flexibility and performance compare with those?
Sorry, are you referring?
The patient responses, you say, is my hand working well?
Yes.
How do your results compare with the results which occupational therapists or the protocols which they use? Have you compared them?
I haven't in my scar work, but I would say in the papers that have thus far, so in the Jerish Herald paper, where they looked at splinting, they used the DASH, the Disabilities hand, shoulder, and arm, and they found that it didn't identify change. And I think that's, I was having a discussion with Sonia, who's up next, about this last night, and there are issues with some of the outcome measures that we use that they don't capture change in terms of functional performance. I think often patients with Dupuytren's disease are probably much like our rheumatoid cohort in that they're very adaptive. And so we're not necessarily identifying the functional difficulties through those sort of standardized items.
Thank you.
You're welcome.